Hello, I am Professor Dr. Manish Gupta. The procedure we are showing here is for external canal atresia and treatment, that is atresiaplasty. You have seen a CT scan where the right external auditory canal was completely bone opacified, and we planned for an posterior approach, that is a transmastoid approach for this patient. And there are two approaches. We can go for anterior approach also, that is transcanal, but that has more chances of complications, injury to the vital structures like facial nerve, TM joint, ossicle chain, etc. So you have seen a marking for the McEvans triangle where we follow the inferior temporal line, the supposedly posterior canal wall, and then the tangent to it. And since the mastoid was pneumatized, it was easy to, and it gives in good surgical orientation because we often open the mastoid via this route. You can see the mastoid being opened, the antrum being opened, and now we plan to follow the attic and additus and attic anteriorly. You can see with the water drops, we can have a view of the incus coming due to refraction, and this gives us an idea that the ossicle chain was intact. So we know exactly where now the canal will be. Starting the drilling towards the canal now. Basically, this congenital malformation of an external auditory canal results due to non-canalization of the epithelial plug in the first branchial cleft. The patient presented with a loss of more than 50 decibels. Conductive hearing loss was there on audiometry. Basically, this was a Schucknecht type C type of atresia, where there is total atresia with absent bony canal, ossicular malformation, missing tympanic membrane, and pneumatized mastoid. Radiologically, we can go for just Doppler classification, where basically decides the candidacy for surgery, and we had a score of more than 7, so it can bring a good outcome in this patient. The diameter of a new canal should be at least 10 millimeters. So accordingly, we dilate the opening. After thinning this atretic plate by a drill, we plan to curettage because it avoids any trauma to the intact ossicular chain and subsequent hearing loss. The bone we encountered at the region of canal was very hard. The patient had grade 2 microtia also, but it was completely asymptomatic or not bothering to the patient or the parents. See, now as we open the middle ear, more and more picture of ossicular chain status is getting clearer. The middle ear was small in size with no evidence of tympanic membrane. You can now see the body of the incus. And after further curettage, deformed malleus will also come into picture. This is the buttock sign where the malleus and the incus appear as two prominences in the attic. The malleus handle was almost buried into this atretic plate, which was limiting the ossicular chain mobility. So after bringing this plate down, the ossicular chain was found to be mobile. You have to be careful while doing curettage at this place to avoid any trauma to the ossicular chain. Again, since we have already opened and seen the second genu of the facial nerve, we know now where the vertical part is lying, so we can avoid further damage. Though we have broken a bridge, but now we will plan for a canal wall reconstruction within tragal cartilage. You can use a bent pick also to remove small bone pieces and see how the ossicle chain is deformed or malformed. Temporalis fascia graft was harvested and placed overlapping all around the canal and in a position with the ossicular chain. Then split thickness skin graft of 0.3 millimeter was harvested from a right thigh using a humpy knife and was placed all around the canal. Pieces of dry gel foam being placed to avoid any displacement of the graft, which will be removed before we place a split thickness skin graft. The cartilage from a tragus is being used for reconstruction of a posterior canal wall. Again, gel foam pack was placed within the mastoid so as to avoid displacement of this cartilage in immediate post-op. This was the skin graft. It is important to measure the length and breadth beforehand. The gel forms are removed so as to keep the graft directly over the temporalis fascia all around over the bony canal. It is important to ensure that no folds are being there, because otherwise there will be a high chances of colostoma formation. After covering the raw area of the bone all around, we place a medicated gel form within the newly formed canal so as to again avoid displacement of these graft. The closure was done with the posteriorly based subperiosteal flap so as to avoid any risk of fistula. The meatus has also been opened with a clean cut, and the skin of it is being inverted inside in a position with the split thickness skin graft so as to avoid any raw area which may lead to granulation and further fibrosis. After this all around suturing, umbilical tape, medicated umbilical tape was placed within the canal, which was removed after 10 days. Thanks for watching.